Welcome to Unit 1, Session 1 of the ACES Aware Ventura County Lecture Series. I am Tomas Torices. I'm the Executive Director for the AAP California Chapter 2, and I will be the moderator this evening. We'll give folks just a couple of minutes to log on. On the screen, you will find as you can see on the screen, the two QR codes. You'll find a few reminders about registering and completing the evaluation. In terms of the registration, the Zoom registration that you received that led you to this meeting today, that is so that you can access the meeting, but we do need you to register with a QR code so that we can have your information for the attendance, please. Also pay attention to the chat box because a lot of links have been placed there as well. So if you don't want to use your phone camera for the registration, you can use the links in the chat.
Hi everyone. Thank you for joining us for this session that is part of the AAVC Provider Training Lecture Series. We hope this session is both informative and engaging for you. Don't forget to register and complete the evaluation so we know who our audience is and how to improve in the future. All who register, including those who are watching this as a recording, will be entered into a raffle for a special ACES Aware Ventura County prize. This lecture is being recorded so you can have access to it on our website at any time. Thank you for joining us on our mission to bring better help, better health, and better hope to Ventura County and beyond.
Thank you, Dr. Landon. Our speaker today is Dr. Moira Szilagyi. She will be presenting on childhood trauma and resilience, trauma-informed care in pediatric settings. Dr. Moira Szilagyi is the president-elect of the National American Academy of Pediatrics, the AAP. Dr. Szilagyi is the primary care pediatrician, professor of pediatrics, interim division chief of general pediatrics, and section chief of developmental behavioral pediatrics at UCLA. Prior to this, Dr. Szilagyi was professor at the University of Rochester. She served as the medical director of an integrated care medical home for children in foster care and kinship care in Rochester, New York. Dr. Szilagyi's research focuses on evidence-based screening and services integration into primary care, and the identification and management of adverse childhood experiences. Dr. Szilagyi has held numerous AAP leadership positions, chairing the AAP New York District 2 Task Force on Foster Care and the National Council on Foster Care, Adoption, and Kinship Care Executive Committee. Dr. Szilagyi is the project investigator of an AAP case-based online educational program to help pediatricians integrate trauma-informed care into practice. After this lecture, Dr. Szilagyi will be responding to some pre-submitted questions. Now, I'll turn it over to our presentation.
Thanks for that very kind introduction and the invitation from the organizers to participate in this training. My talk is a bit of an overview, but it is focused on what I see as the emerging future of pediatrics, relational care that is trauma and resilience informed. And you have a lot more trainings ahead of you that will go deeper into these topics. Today's talk is based on the pediatric approach to Trauma Treatment and Resilience Project. It was a joint effort by the AAP, the University of Massachusetts, and the Department of Pediatrics at UCLA, and funded by the Substance Abuse and Mental Health Services Administration. By the end of the talk, you should be able to discuss the high prevalence of childhood trauma, the clinical importance of identifying and responding to it, recognize our role as pediatric professionals in promoting safe, stable, and nurturing relationships. And we'll also spend a little bit of time today describing the judicious use of ACE screening. So why is trauma-informed care important? Research has shown that childhood adversity and trauma is very prevalent, with rates ranging from 48 to 90%, depending upon the population being studied. Research also shows that cumulative childhood adversities alter gene expression, brain development, and immune system function in ways that affect lifelong health. Moreover, there is something that we can do about it, and that something is derived from research in fields that are largely outside of pediatrics. Those are the fields of epigenetics, early brain development, attachment, parenting, resilience, and trauma-informed mental health care. But first, let us agree on what we mean by trauma. SAMHSA has defined individual trauma as that which results from an event or a series of events or a set of circumstances experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. Trauma can affect people of every race, ethnicity, age, and sexual orientation, gender, psychosocial background, and geographic region. Individuals may experience the traumatic event directly, witness an event, or hear about an event that affects someone that they know and care about. Trauma can occur at any age or developmental stage. It can affect an individual or families, groups, communities, specific cultures, and generations. It can be made by humans, such as war or racial strife, or it can be a natural trauma, such as a hurricane or a wildfire. Two people may be exposed to the same events, but experience and interpret them in vastly different ways. Various biopsychosocial and cultural factors influence an individual's immediate and long-term reactions to trauma. For most, regardless of the severity of trauma, the short-term or the enduring effects of trauma are met with resilience, that ability to rise above circumstances or to meet challenges with fortitude in the presence of supportive relationships. For some people, reactions to a traumatic event are temporary, whereas others have prolonged reactions that move them from acute symptoms to more severe, prolonged, or enduring mental health consequences. For example, such as anxiety disorders, substance use, and mood disorders, or medical problems such as asthma, headaches, and chronic pain. Even if an individual does not meet the diagnostic criteria for trauma-related disorders, it is important to recognize that traumas still can affect their functioning in their lives in significant ways. Children can, in fact, have three general outcomes after trauma. They can emerge resilient, they can have latent disease and be asymptomatic, or they can be symptomatic. The symptoms can range from mild to severe, and we may see either brain or body symptoms or both. I began caring for children in foster care in the 1980s as a pediatric resident. This population that I took care of had a high prevalence of prenatal substance abuse exposures, child maltreatment, and chaotic living environments. Often they presented with multiple symptoms, including developmental, mental health, behavioral, and physical health problems, sometimes with symptoms in multiple domains. The most compelling symptoms, however, were in the areas of mental health and development. Fully 60% of the children under 5 in my practice had developmental delays in more than one domain upon the use of a validated developmental screener. And 80% of the children aged 5 to 18 in my care had mental health problems, sometimes multiple. In fact, many of my children had been prescribed psychotropic medications for multiple mental health diagnoses, and sometimes children as young as 4 years of age. But I also noticed that some children who found stable placement in a nurturing foster or kinship home improved, sometimes dramatically. It was mostly the younger children, but sometimes it was even the adolescents. In medical training, the Law of Parsimony teaches us that we should look for a unifying diagnosis when we see a patient present with multiple symptoms. Look for one solution to the problems before us and not multiple. This is known as Occam's razor. Well, how does Occam's razor apply here? What physiology could explain all of this? At the time, there really were not any answers, but over the decade that followed, we began to elucidate the physiology of trauma. The landmark Kaiser Permanente ACE study was published in 1998. This study was done in 2 waves in Kaiser Permanente outpatient settings, where over 17,000 adults, average age 65 years, mostly middle and upper income, white and college educated, completed the original survey. The 10 questions on the ACE survey are about intrafamilial relationship trauma, and the score could range from 0 to 10. The ACE score was not weighted in any way, which means that the type of trauma, the severity, and its frequency were really not assessed or considered in the scoring. In this low-risk Kaiser Permanente population, nearly 2/3 of participants recalled exposure to at least one ACE, and 1 in 8 recalled 4 or more during their childhood. Kaiser Permanente has excellent health records, so the authors were able to review the participants' health outcomes and discovered that across their population, as the ACE score increased, so did a variety of poor health, mental health, behavioral, and social outcomes. There was a dose-response relationship between the ACE score and poor outcomes, including early mortality. And multiple studies since have confirmed these data. Since 2009, the CDC has been conducting an annual telephone survey of different subsets of 48 states and have included ACE questions on their survey. Sadly, the prevalence of ACEs in this multi-state telephone survey reveals that not much has really changed over 2 decades, except that the percentage of adults reporting 4 or more ACEs is higher at 16% in the more representative CDC survey than in the Kaiser Permanente survey, where it was 12.5%. The authors of the original ACE publication suggested that ACEs led to the adoption of high-risk health behaviors such as substance use disorder, and that explained the increasing disease burden with increasing ACE score. However, they could not explain why some individuals with high ACE scores who did not engage in high-risk behaviors had the same terrible outcomes as those who did. Over the next decade, scientists began tying together work in gene expression, early brain development, and neurohormonal stress responses, providing new insights into how trauma can become biologically embedded. In 2012, the American Academy of Pediatrics published a technical report and policy statement on what is called toxic stress, in which they summarized this research. It turns out that a little bit of stress is good for us, as it promotes learning. This is called positive stress. More serious stress, such as a hurricane leading to temporary loss of housing, is still tolerable when children have buffering relationships to rely on. However, significant stress can lead to prolonged activation of a child's stress response systems in the absence of those buffering relationships. ACEs are the primary example here because by definition, family relationships are insufficient to meet the child's stress needs. And even worse, in the case of ACEs, the trauma may even be caused by the child's caregivers. Stress basically becomes toxic stress when stress activation is not buffered by nurturing caregiving. ACEs are one type of childhood trauma, and perhaps the most profound because they occur within the family, which is supposed to be a child's safe harbor. But other cumulative traumas can also lead to the toxic stress response: racism, bullying, significant community violence, forced family disruption, and so on. And so we need to understand the context of children's lives as pediatric professionals. How does stress wreak its harm? We all learned about the fight or flight and even the freeze response to stress in medical school. That when the amygdala, the brain's alarm system, perceives danger, we can either freeze, and here you can think about that deer in the headlights, or with the activation of the hypothalamic pituitary adrenal axis, or HPA axis, we can go into fight or flight. We all know what this feels like. It is when our heart rates and our blood pressure goes up, we sweat, and we just can't seem to think clearly in that moment. The fight or flight system is really designed to deal with short-term threat, like the rattlesnake on my recent hike. And the feedback loops that are built in normally shut the system down when the threat subsides. It's actually designed to run for about 20 minutes, just long enough to get us out of danger. But when the tiger lives in your home, as it does with ACEs, or in your life, as it does with racism, community violence, and bullying, and is severe, frequent, or prolonged, and buffering is insufficient, the neuroendocrine stress response system can become dysregulated. Prolonged cortisol dysregulation leads to changes in the immune system function, gene expression, and other systems changes. The effects on the immune system can result in reduced immunity so that we have less capacity to fight off infection. It also leads to an increase in the pro-inflammatory pathways. These are stimulated and set the stage for inflammatory diseases such as asthma and heart disease as we age. Changes in gene expression can alter cortisol-mediated feedback loop that normally shuts down fight or flight responses. In other words, dysregulate cortisol being elevated for any period of time leads to cortisol dysregulation. Altered gene expression in response to what is happening in the environment can also affect brain growth and development. One of the arguments supporting ACE screening is that it can be used to identify patients at risk for developing toxic stress or experiencing ACE-associated health conditions, signaling the importance of intervention. Let's focus on the brain for a moment. This is arguably the most important organ in the body. Stressors have their most profound effects when the brain is rapidly developing, as it is in children, especially in early childhood, when the foundational architecture, connections, and circuits are being built in response to the environment. When a child lives in a neglectful or chaotic home, the stress responses are frequently or chronically activated. When buffering by safe, stable, nurturing caregiving is insufficient, the complex interplay of the neurohormonal stress responses and the epigenetics, or changes in gene expression, impact brain development. The brain's alarm system, or amygdala, hypertrophies, and the learning and the executive functions essentially shrink or they go offline. What does cumulative childhood trauma or toxic stress look like in children or in teens? For most children, it does not look like the adult with PTSD or the combat veteran with PTSD that we all learned about in medical school. Rather, children can present with a host of responses depending upon their developmental age when the trauma happens, the type of trauma, its severity, and the availability of buffering. Trauma early in childhood is worse, as is more severe trauma, and especially trauma that occurs in the absence of buffering relationships. Symptoms can range from sleep disorders to hyperactivity and inattention, developmental delays, and aggressive behaviors. And multiple symptoms are common. In seeing children, we must consider trauma as part of the differential diagnosis when we see certain symptoms or hear about certain risk factors. Otherwise, we can waste a lot of time and energy pursuing an incorrect diagnosis and treatment. And this allows trauma to further biologically embed. Some children, of course, have sleep, behavioral issues, or other symptoms for reasons unrelated to trauma. But just as we have to understand the cause of a child's limp to consider appropriate care, we must understand the underlying etiology of symptoms that may or may not be related to trauma. And one side note, our genetic blueprints are constant, and each child has their own genetic strengths and vulnerabilities. The differential sensitivity to context hypothesis suggests that some children, whom we refer to as our dandelion children, are relatively more able to withstand life stressors. They turn out pretty well whether or not they are raised in not so okay conditions, as long as they are not extreme. Our orchids, on the other hand, are more sensitive. They thrive and they even exceed expectations in rich circumstances, but they may wither when conditions are not so ideal. So genetics matters and the environment matters, but it is that interaction between our genes and our environment that drives the adaptation of the brain to its environment. So that law of parsimony, Occam's razor, I finally had my answer. Childhood trauma and adversity in the absence of buffering relationships can result in all the negative outcomes we see in childhood and throughout the life course. The etiology is trauma, usually severe, frequent, or chronic. The mechanism is toxic stress, the unbridled activation of the body's physiological stress response systems in the relative absence of nurturing relationships. The CDC has modified their ACE pyramid to consider that things are a bit more complex than they originally described them to be. In particular, historical, cultural, social, and family contexts now occupy a much larger portion at the base of the pyramid and are all important in child development and outcomes. These represent the area where we, as pediatric professionals, interact with children and families and where we can do our preventive work. While the first 3 years of life are critical in building the foundational architecture of the brain remains vulnerable throughout childhood. During adolescence, extensive pruning of neurons and increasing connections among neurons are very common. This is typical development. These processes can be displaced or disrupted by trauma and by toxic stress. As pediatric professionals, we know that times of rapid brain growth and development are not only times of great vulnerability, but they also present amazing opportunities for us to improve outcomes. So what can we do to help children and families? It turns out that in addition to fight, flight, and freeze responses to threat, we learned about there is a fourth body response to stress, the affiliate response. This is mediated by the hormone oxytocin. It is the fourth response, and it provides a way forward since relationships can prepare us to deal with stress and buffer its impact. When the amygdala is alerted to danger, oxytocin is released by the posterior pituitary. If the child looks around and finds no help, or worse, the caregiver is the source of the danger, the fight-flight response is triggered. However, if the child looks about and finds a supportive caregiver or social network, the stress response is turned down or dampened, and the affiliate structures of the brain are engaged. As noted early, PATTER, the Pediatric Approach to Trauma Treatment and Resilience course, was developed to help pediatricians and other professionals respond to childhood trauma. We set out to create a trauma-informed pediatric workforce and generate a team of trainers and clinicians equipped to help caregivers promote resilience and buffer the impact of stress and trauma on their children. We have developed an extensive trauma and resilience-informed curriculum and resources to go with it, and we've been training pediatricians and their teams nationwide using ECHO, which is an online telementored case-based learning system. We have 2 levels of training, trauma-aware and trauma-responsive. Today, I'm going to highlight some of the basics of the first level, aware curriculum. When we do this training, we actually ask pediatricians to bring their teams with them because this type of care is a team sport. Trauma-informed care is defined by the National Child Traumatic Stress Network as medical care in which all parties involved assess, recognize, and respond to the effects of traumatic experiences on children, caregivers, and healthcare providers. It changes the question in medicine from what is wrong with you so I can fix you to what happened to you and what is strong with you so that I can help you heal. Much of the PATTER work is rooted in promoting resilience. This is work that is truly in the pediatric wheelhouse. We already do a lot of this every day, often without recognizing where it fits into the framework of trauma-informed care. Let's consider the definition. I love this one by renowned developmental psychologist and scientist Ann Maston. It reads that resilience is a dynamic process of positive adaptation to or in spite of significant adversities. For the individual, growing in resilience is dynamic and developmental in that it occurs over time and is dependent on the interactions between our genetic code and our environment. Researchers initially thought that resilient individuals must have some invulnerable trait that enable them to rise above awful circumstances. But decades of research instead identified the remarkable power of the ordinary in human development, which makes sense from an evolutionary viewpoint. Ann Maston refers to resilience promotion as ordinary magic because research has shown that resilience develops in the give and take of safe, stable, and nurturing relationships that are continuous over time. These are our attachment relationships. And in the growth that occurs through play, exploration, and exposure to a variety of typical activities and resources. Although we all know that a sizable proportion of our child population has neither access to these typical activities and resources, nor do they live in stable, nurturing relationships. Research has also identified personal and cultural and community resilience factors. But for the purposes of this talk, we're really going to focus on the 7 personal resiliency threads that weave together the fabric of a typically developing human being. The acronym THREADS was coined by Dr. Heather Forkey from UMass, and it helps us remember what these resilience factors are. They are having a thinking and learning brain, a sense of hope, faith, and optimism, being able to regulate our emotions and behaviors, having a secure attachment relationship with our primary caregiver, achieving age-appropriate developmental milestones, and having a larger, healthy social network. The attachment relationship, which is in the middle of this list, should probably be the first on the list because it is the warp thread on the loom. It is the context in which all of the other resilience factors develop and in which they are woven together or not. As pediatricians, we do not learn much about attachment in training, and yet we assess it, we use it, and we nurture it all the time, often without recognizing we are doing so. In the blink of an eye, when we walk into an exam room, we assess the parent-child relationship before us. Is it warm and supportive, or is the parent disengaged and the child demanding? We begin teaching attachment promotion skills in the newborn period by pointing out the infant's gaze and encouraging the back and forth cooing called serve and return between parent and infant. That is the first of many conversation and begins the building of the parent-child relationship and the architecture of the child's brain. More recent literature on resilience no longer defines it in terms of overcoming adversity, but considers that it is the typical way of things when the relational context of the infant or child's life is in good working order. Resilience development relies on oxytocin, the affiliate hormone, and the brain's affiliate pathways, including its reward structures. The affiliate pathways of the brain move from the amygdala through the midbrain to the prefrontal cortex, the very areas of the brain that are impacted by trauma. And it also relies on the biobehavioral synchrony between the infant and their caregiver. This is rooted in the parent's ability to hold their child's mind in mind, match their affect, and to identify and respond effectively to their needs. The attachment relationship is vital for children because it serves multiple functions for the child. It is where the child achieves a safe harbor and the security to explore the world and the world of relationships. It is where we develop our sense of self as it is reflected back to us by our caregivers, and where we develop our sense of self in relation to others and begin our social emotional learning. It is where we develop both emotional regulation and executive functions. This occurs over about 2 decades, but it begins in the newborn period as our parents help us by providing emotional regulation for us, by dampening our stress responses, modeling regulation for us, and then co-regulating with us until we integrate those skills into ourselves. And the same thing happens with executive function, as parents initially provide it and then teach them, model and teach them to us. It is where we achieve age-appropriate developmental milestones and develop a sense of self-efficacy and confidence. Trauma, in the absence of nurturing caregiving, hijacks the very structures of the brain that the affiliate response relies on to build resilience: the amygdala, the hippocampus, and the prefrontal cortex, among others. The traumatized brain, with its overdeveloped alarm system, becomes predisposed to watch for danger. It prioritizes the skills of survival over the development of the thinking and learning and regulatory structures that really depend on the availability of that safe, stable, nurturing caregiving. Trauma frays the threads of resilience. The thinking and learning brain is shut down because we're in fight or flight. Planning for the future is shut off to deal with present danger. Regulation is overwhelmed by the fight or flight responses. We are not controlling a situation, but we're reacting to it. And in toxic stress, by definition, we do not have supportive relationships to rely on. And our developmental learning often regresses because of the learning structures of the brain being impacted. So what does being frayed look like? Trauma frays the threads of resilience, and we use the FRAID acronym, another Dr. Forkey special, that reminds us of the common symptoms that we may see in children who have experienced trauma. We may see threats and fears, a child who is very anxious, a child with regulation difficulties in behavior and emotional regulation. We may observe disrupted attachment. We may see externalizing behaviors such as tantrums, yelling, or disorders of functional things such as elimination and sleep, characterized by yawning in this acronym. We can see children who are having educational and developmental difficulties, or at one end of the spectrum, a child who is defeated, delayed, and detached. The great news is that the sciences of resilience and attachment reinforce that adversity is not destiny, and relationships that nurture the affiliate response make all the difference. There are a number of models that list the principles of trauma-informed care. In general, it's not a checklist. It is an approach, and it requires system-wide changes in our health structures. It requires us to do ongoing assessment and incorporation of new knowledge and skills. It requires that we have safe environments to work in, both physically and psychologically, that we work in teams, that we consider those with lived experience in our advisory boards and our structures. Trauma-informed care work cannot occur in isolation. According to the National Child Traumatic Stress Network, trauma-informed care is care in which we realize that trauma can affect children and families. We recognize the signs and symptoms of trauma. We resist re-traumatizing individuals. We respond to trauma in ways that promote recovery and resilience. So let's look at some trauma-informed care approaches from our PATR Level 1 Trauma Aware course. And I assume some of you might be a bit skeptical that we can do this work in a busy pediatric setting. So where do we begin? We begin in PATR with discussing engagement. But engagement requires first that children and families feel safe psychologically and physically in our environments and in our relationships with them. I have condensed the science of engagement into one slide. We establish safety and engage families and patients by how we greet them, ask about their concerns, by being fully present in the moment with them, by using open-ended questions and a motivational interviewing style. MI in this slide means motivational interviewing and not Mission Impossible. And we use an attuned, attentive, reflective listening to learn about the context of the child's and the family's life. We partner with them about what they think might be going on and about ways that the family and the culture might respond to trauma that is helpful. As noted, the original ACE study was done on a low-risk population of adults at Kaiser who had a high prevalence of ACEs. This suggested that it's not always clear who has ACEs or other social risks, and it is why universal surveillance is fundamental. It is why we suggest starting with a strengths-based interview. Tell me what you enjoy about your child or your family. and then moving into universal surveillance for trauma. Some evidence-informed questions that we can use are, has anything bad or scary happened to your child, either since I last saw you or ever? Has anyone come or gone from your home lately? And of course, we can always ask about what a parent's concerns may be. Parents also come to us with symptoms or concerns, or we may observe symptoms such as the child tearing around the exam room, or aspects of the relationship, a parent or teen who are disengaged from each other. Any of these things should alert us to explore further. And we can use the tone and tenor of the parent-child interaction as a relationship vital sign. Ideally, we start with conversation, and we might use a screener to elicit other concerns. Atypical results on the screeners that are already supposed to use in practice should alert us to explore interfamilial and other adversities further. Screening an atypical response on a maternal depression screen, a developmental screener, or a mental health screener is cause for concern. And we have to be careful including any screener into practice. We have to be clear about what we are looking for, who we're going to screen, the child, the parent, or both, how we're going to do that screening. Are we going to do it verbally or on paper or electronically? When are we going to screen and how often? In terms of trauma screening, once is not enough since trauma can accumulate over time. And what are you going to do with the results once you have them? Who's going to review them with the family, validate them, and then how are we going to respond to them? The ACE surveys in particular are concerning because they ask very personal questions and questions that can actually bring back bad memories and re-traumatize individuals. It's really important that we have a script when we are going to introduce these surveys. Most individuals, in fact, appreciate being asked, but some of the questions really can be triggering. ACE surveys do not address symptoms or strengths or protective factors or positive childhood experiences, and that is one of the concerns that a lot of trauma experts have about them. They were developed to be population instruments, and they are not designed to be predictive at the individual level. And many pediatricians are concerned about using ACE surveillance for many other reasons. We don't have enough time in our busy practices. We're already running through our days. Is there a cost associated to this? How do we secure the information? Is it available in the languages in which I need to speak with my patients? And we may also just not have the resources either in our offices or in our communities to know what to do with the results after we find them. But once we have identified trauma risk factors or symptoms, we also, as providers, need to have something to do in response. In Patter, we built a toolbox of practical guidance, skills, and tools for pediatricians to use in weaving the threads of resilience together or back together. We took most of these tools from the sciences of evidence-based trauma-informed mental health care, parenting, attachment, and resilience. And some families don't need very much from us, as you all know, while others really need us to have a very large sewing kit to help them out. And some are going to need referral to evidence-based mental health treatment. In Patter, we teach pediatricians about ACEs, toxic stress, trauma symptoms, attachment, and resilience. We then discuss how to help families and children. We talk about engagement and about asking about risk factors and symptoms. As part of this, we discuss ways providers can discuss trauma and its impact on children or families. For example, when a parent raises concerns about symptoms such as sleep problems and severe tantrums, we can say, sometimes children have these responses when something bad or scary has happened to them, or there has been a major change in the family, such as someone coming or going from the home, or being exposed to violence. Have any of these things happened in your family or to your child? We can explain the effects of trauma or adversity to parents whose child has been exposed to violence, for example, by describing how the brain's alarm system is always on alert and scanning for danger. If the brain senses danger, even if none is present, the alarm goes off. Even a harsh tone of voice might remind the amygdala, that our brain's alarm system, of danger and trigger the child's tantrums or their call for help. The ever-vigilant alarm system and the stress response systems are really just doing their job. This is an unintentional response on the part of the child. The brain is responding reflexively to keep the child safe. From the alarm system's viewpoint, it's as if the trauma is happening now, even if it occurred in the distant past. And that is the way the child feels, as if the trauma is happening now. The child's responses might have actually been adaptive when the child was living in danger. But in a child care setting or a classroom, or even at home after danger has passed, the child's overwhelming response is maladaptive. It is really important, however, that we normalize the response, saying that the child's response is a normal response to what has happened to the child. This takes the blame off the child and helps increase the understanding of the parent about the child's responses. The word danger, interestingly, contains the word anger, which is the emotion that most adults observe or see when a traumatized child is responding outwardly to danger or threat. So we teach about helping parents identify the underlying emotions that the child is experiencing and building the child's emotional vocabulary so they can use their words to talk about what is bothering them or happening to them. Many other feelings can look like anger. We can teach caregivers that children who have experienced complex trauma, especially children in foster care, living with community violence and other problems, may carry around a lot of different emotions in their invisible suitcases. Anger might in fact be the tip of the iceberg for a lot of other emotions the child is experiencing: fear, anxiety, disappointment, frustration, grief, or guilt. We also teach pediatricians about the cognitive triangle, that parents come in with concerns about behaviors. So instead of offering behavior management advice, we need to understand more about what the behaviors tell us about a child's emotions and thoughts. Maybe the child who is aggressive or running out of the classroom at school is being bullied, or the new male teacher has a loud booming voice that reminds them of violence at home. The child is reacting to the real bullying or the perceived violence, the loud booming voice of the teacher, and responding with their fight or flight response. Keeping a child's mind in mind and trying to understand what underlies the behaviors that we are seeing is really important. With a verbal child, we can actually explore this when the child is calm, but we need to explain this to parents to help the caregiver understand the child's feelings and thoughts, to essentially hold the child's mind in mind. We can also teach caregivers another evidence-based approach, building the child's emotional vocabulary. Providing names for emotion helps children express their feelings in words. You can't do this when the child is in fight or flight. You have to do this after the storm has passed. Most children have about 4 words: happy, sad, angry, and scared in their armamentarium. It's like getting that tiny 4-pack box of crayons at a restaurant. But there are so many other words for emotions. We can encourage caregivers to teach those emotions: disappointed, frustrated, hurt, and even link a feeling to a color. Disappointed might be red, frustrated orange, and blue sad. Reading books and asking about what a character is feeling and how we know is a great way to teach emotions to children while building literacy skills and the parent-child relationship. We talk about the parent as the child's emotional container and growing regulation skills. A child's behaviors, such as aggressions, outbursts of anger, or trouble sleeping, can be overwhelming or frustrating for any caregiver, teacher, or child care provider, or even a health professional. Children can only regulate if the adults around them are regulated. The adult has to be an emotional container, at least outwardly, who can remain calm and modulated and hold the child's strong emotions. This helps over minutes to de-escalate the child's stress response, much as the mother soothing the crying infant does. This is hard work, even for adults with good self-regulation. For caregivers whose own self-regulation is shaky, this is much harder. For the child with trauma, we never use time out. It is important for the caregiver to remain present, calm, and supportive, regardless of the child's age, toddler to teen. This reassures the child or teen that they are safe and cared for. that the caregiver is there for them and has their back. The adult might need to hold the child from behind, to sit with them, to just be there, ideally at eye level. Some children do not want to be touched. In this case, it is still important for the adult to just remain present and remain calm. We summarize some of the anticipatory guidance for helping children who've been traumatized in the 3 R's concept in Patter: reassuring the child they are safe, having routines, and helping the child regulate. We have an infographic on this topic available in both Spanish and English through the AAP. There's a lot going on in this picture. The caregiver is being a supportive emotional container, holding and soothing the fearful child and dampening their stress responses. The parent might also be talking in a higher pitched voice to soothe the child and reassure them they are okay. Once a child is calmer, the parent may describe the child's feelings out loud, teaching the child the language for their emotions. Later, they might read a book together and discuss what the child went through a character in the book. This parent is using reassurance by holding and co-regulation by remaining calm. Sleep issues are very common after trauma. Both the amygdala and the reticular activating system are heightened. So let's look at the 3 R's in relation to sleep disorders. One cannot reassure a child who has experienced trauma enough that they are safe using words, touch when tolerated by the child, and a safe space. I love you, I've got you, you're safe. Caregivers can help the child to create a safe spot at home using a tent, a pile of pillows, building a fort, or finding a quiet nook in the home. Sleep is often difficult because the child has fear of separation from the caregiver or even losing the caregiver during sleep. We can recommend using twin loveys through which the child can communicate with the parent even when they are physically apart. Caregivers can leave a family photo by the bedside and talk about how everyone in it will see each other in the morning or after nap time. We can suggest that the parent leave a piece of their unwashed clothing so the child can smell their scent even when they're gone from the room. For an older child, you can leave loving messages and favorite loveys behind. Routines are important for children, and we recommend them all the time to families. And we have certainly all learned during COVID just how important reestablishing or developing new routines was to dampen our own stress responses. Routines communicate safety and predictability. They shut down the stress responses. After trauma, bedtime routines may have to be enriched with the parent reading more books, staying a little longer with the child, and offering more reassurance. Bedtime routines prepare the body for sleep, and they also build self-regulation skills as the child learns to manage them, eventually adding to their sense of self-efficacy. Teaching self-calming to both the parent and the child helps to build skills for self-regulation. Self-calming skills are evidence-based ways to promote regulation of emotions and behavior before or after trauma has occurred. We can recommend belly breathing, music, dancing, vestibular activities like jumping and swinging. Sesame Street and Communities actually has wonderful resources for families, and I use them from toddlers through teens. Elmo's Deep Belly Breathing and Big Bird's Safe Nest are two wonderful videos to refer families to. We all teach positive parenting strategies to caregivers. For traumatized children, we can teach caregivers to intentionally incorporate the 3 R's and a few other strategies that build attachment, self-efficacy, and regulation. Catching the child being good 5 to 6 times a day and commenting specifically on their effort is a great way to build a healthy child. It focuses the caregiver on the child's efforts and strengths, and it also changes the narrative in the home, since many traumatized children and adults have never heard much good about themselves. We can also model this in our settings with children and parents, especially with families that we all find challenging, by catching the parents being good. We also recommend that parents and children spend time together because that builds attachment and it also builds the child's sense of self-efficacy. Special time in is derived from trauma-informed mental health care. It is a more intentional approach to building the attachment relationship. The caregiver sets aside special time to spend with the child each and every day. The parent selects the time, but the child selects the activity. Picture phones and other media are off. If the child is very young, the parent can offer the child a choice of favorite activities. Would you like to build with blocks, or would you like to play with your farm animals or read a book? Setting a timer for 15 to 20 minutes can signal both the parent and the child when the special time is over. And the parent can also praise or offer occasional comment to the child during the experience. Wow, I really like the way you put those colors together in your puzzle. Caregivers who have their own trauma histories or multiple stressors may appear to have so many needs that it can seem simply overwhelming and insurmountable to teach any of these strengths, let alone all of them. But success breeds success. So in empathic relationships, we can break the long staircase into smaller and smaller steps so that the parent can experience some success. And we just want to go back to basics of trauma-informed care. We have to offer safety, empathy, validate how hard parenting is, and try to understand what has happened to the caregiver and what they are dealing with and what they bring to parenting. If we can partner with them to find a small strategy that they can work on and achieve some success with, we will be building the foundation for future work with them. For the overwhelmed caregiver or the one with trauma, we probably need to check in more often and help them build skills slowly over time. It's important to prescribe self-care to help the caregiver find what helps them to modulate. As always, we offer hope of recovery and faith in their skills. And we also want to find a list of community-based services such as housing and food resources, etc., that we can offer to reduce some of the stress in the home. We must remind parents that when they start changing what they're doing as parents, the child may initially become more dysregulated for a couple of weeks until they get used to this new style of parenting. So we have to prepare parents to expect that. And we have to do very close follow-up, care coordination, and referrals. In summary, the PATTER goals align well with the goals of ACEs Aware. Trauma-informed care requires that we first establish safety, both psychological and physical, for our patients and for our families and our staff. It is only when everyone feels safe that we can begin to build trust with our patients. Trauma-informed care is relationship care in which providers partner with families who are the experts in their children and their family, while we are the experienced in healthcare. They are also experts in their own culture, and so we need to understand their culture through their eyes. ACEs Aware will teach you about these 7 evidence-based strategies known as stress busters. We have discussed some of them today: supportive relationships, quality sleep, and mindfulness. Supportive relationships are fundamental to children, but sleep, healthy nutrition, exercise, and time in nature can also help with regulation, as can referrals to community-based services such as housing and food resources. And this is really crucial because adults cannot engage in other work until their family's basic needs are met. So is any of this working? By the end of 9 cohorts of our Level 1 Trauma Aware course, we had trained over 203 physicians and about 450 of their team members. Our participants were predominantly white females, but otherwise represented the demographics of the AAP. And we've actually trained people now, physicians in 47 states across the country. And throughout most of Level 1, pediatricians really were able to compare their knowledge base at the beginning of training with their knowledge base at the end. And they moved from a basic application of most of these principles to being highly experienced. We also asked participants the effect of the course on their learning and their ability to change practice. And the comments indicate that participants are able to integrate content into practice and to use the knowledge gained to educate others. And these are some of the resources that are available through the AAP. We just published a new book on childhood trauma and resilience that is available through the AAP and Amazon. The AAP also recently published a new toxic stress policy statement, together with our clinical report and policy statement on trauma-informed care and trauma-informed systems of care. We also have infographics that are available, and our AAP PATTER website is up, and you can find that at aap.org/PATTER, and that's open to the general public. And you can find the videos for our trainings on that site. I'd like to thank, as always, my PATTER team at UCLA the AAP and UMass, and our friends at the National Child Traumatic Stress Network. And I just want to say that parents are the magicians of ordinary magic, and we pediatricians are their assistants. We use our relationships with caregivers and children and the continuity of care we have with them over time to focus on the parent-child relationship to build or rebuild child and family resilience. Thank you so much, and I'm happy to take your questions.
Thank you, Dr. Szilagyi, for that informative presentation. I want to remind everyone, if you haven't done so, please remember to register because we need that for attendance. We will now turn it over to the Q&A portion. Unfortunately, Dr. Szilagyi wasn't able to join live, but she has prepared some responses to a few pre-submitted questions, which we will now share. Is the pattern training available to anyone who is interested? Can you please provide a bit more information on that?
Hi, thank you so very much for that question about pattern training. Elements of the pattern training are available on our AAP pattern website, and that you can access that even if you're not an AAP member at aap.org/pattern. On that website, you can see the videos for all 18 sessions of our pattern training. They're each about 25 to 30 minutes long. And you will also find some videos that demonstrate asking about trauma and how to engage families around these topics. We also have some infographics available about the 3 R's up on that website. You can also find links to our recently released clinical report on trauma-informed care and our recently released policy statement on trauma-informed systems of care. We also just recently published a book called Childhood Trauma and Resilience, a practical guide that you can access, but that does, of course, have a cost associated with it. But thank you so much for asking that question. The pattern echo training itself is currently not available. We're looking for funding and hope to bring it back in the near future. Thank you.
Going back to the idea of Occam's razor, how could we, as clinicians who may be bringing up a host of different issues with just one single patient, help to address the overlap of various needs that may be presented?
Thank you for that questions on Occam's razor and how we as clinicians can bring up these complicated issues in the care of even just a single patient when a family comes to us with a multiple host of concerns. And we all know what this is like, and we have to really take the same approach that we take whenever a patient comes to us with a list of issues. We have to try to figure out what's the most important thing to take care of right now, kind of what's the hurry in today, and what do we need to do to kind of get things to calm down at home. If a family has needs around housing and food, those are priority areas, because if families can't meet their basic needs, they are not going to be able to regulate their own emotions enough to attend to the other issues that a child might have. We can always, when a parent brings a laundry list of behavioral and emotional issues to us, ask them to identify their predominant concern. If they're unable to do that, some families will say, it's all concerning. Maybe what we can say is, well, when I heard you say this and thus, it kind of seemed to me that maybe we should pick one of those to work on. How about we work on the sleep issue, because that seems to be a big problem. And then we can start teaching families some of the tricks of the trade. And depending on their living circumstances, we may have to make some modifications with that. But certainly starting with routines. I often use the B system, the bath, brush, book, and bed, to start teaching the ideas of routines. But really it is that prioritization according to what the needs are to try to get things calmed down, reduce the stress in the family, and then reduce things down to small steps so that the parent can have some success in helping the child.
A common concern is that when we start to screen we'll be unwittingly opening up Pandora's box. And then the fear is that we will not have the right tools to address our patients' needs. Can you talk a little bit more on what we can do to prepare ourselves for this shift?
So thank you for that concern about unwittingly opening up Pandora's box when we fear that we might not really have the right tools to address our patients' needs. And this is a very real concern. I think it's really important for practices when we take on this work in trauma-informed care that we work as a team to identify what our resources are. One of the ways that practices can do this is actually to go discovery shopping. And what I mean by that is walking through your practice as if you are a patient and a family, from the time they get to your parking lot, through your front door, into who greets them, what's in your waiting room, what does that look like, what are the messages you're conveying, is there stuff to read, what are there posters on the wall, who comes out and gets the patient, is everybody introducing themselves, explaining their roles, are you offering the family simple choices along the way and the child? Do you want your blood pressure today in your right arm or your left arm? It is these simple things that are engaging for families and give them a sense of some control in your practice. And then, of course, if the provider during the course of the visit identifies either things that have been happening at home or outside the home that are affecting the child and the family, it is really important to have researched the community resources and the resources in your own practice and your healthcare system. Do you have a social worker on site or a care coordinator or a psychologist? If not, are they readily available in the community? It is very hard to screen for things and then find that a parent or child has a need and not be able to respond to that. And the one thing that we can always do is we can always listen to a family. We can always validate for them their concerns. To just say, I can see how hard this is for you, is very validating, and it's in fact empowering. And many families will just take that validation and go out and search out their own needs. But ideally, we develop the resources and the skills in our own offices, and then we know what those resources are out in our community, and we can refer families to them. It's also a good idea to follow up and make sure that they made the connection, and if not, why not? What were the barriers to them getting to those resources out in the community? A lot of communities do not have trauma-informed mental health care, and so that's a big gap in care in the community. But not every family needs to go to such high-level subspecialty care. Much of the care that families need, we can, through our relationship with our families and some simple advice and direction, we can provide for families in our office settings.
I love the tiger analogy. Is there a way that you can bring this into your practice as an explanation for how ACEs may appear?
Hi, well, thank you. Yes, we like the tiger analogy also. And in talking about ACEs with families, that's probably this kind of trauma to talk about because this trauma occurs within the family. And talking about this in a way that is not blaming is very important. And so one of the ways that I get to this is the very first time that I meet a family, whether they're coming in with their teenager or their newborn, I say, can you tell me something about your own childhood? How were you raised? And are you raising your children the same way? I often don't even need to hear the response. I can tell from the look on the face, the parent's face, what their childhood was like. And if I see distress or, oh no, no way, it's an opportunity for me to explore that further and to learn a little bit about how that parent was raised. I might then say, how has this impacted your own parenting? And they often are, if they haven't already connected the dots between their own childhood and their own parenting, many of families right in the exam room during that conversation will say out loud, oh, I never really thought about it before, but it really is affecting my parenting and I want to do things differently. And it is a wide open door for us to walk through as providers at that moment. So that is how I best approach it, I think. It's also great when you're seeing families back to ask if anything has changed in the home since you last saw them. In my world in foster care, there were always children coming into the home and going from the home. And this used to create a lot of grief and loss, not just for the foster and kinship parent, but often also for the other children in the home. And they would be fearful that they too would be leaving shortly. So, but even in families, birth families, sometimes a grandparent's moved in or someone's recently passed away, or there's been parent conflict and now they're separated. And it's an opportunity. That question can really uncover situations that are really important for us as providers to know and address to figure out whether or not families need some additional help and resources.
What is the trauma-informed care approach to a patient who has received medical care in the past, which did not take a trauma-informed approach and perhaps even created feelings of distrust? In other words, what are some suggestions for how to repair and establish trust in an already strained relationship?
And so this question is about the trauma-informed care approach to a patient or a parent in the past who has received medical care that did not take a trauma-informed care approach. And now I, as the provider, have to try to develop trust with someone who has probably lost their trust in the healthcare system and in us as providers. And I think it's the same way that we always build trust. We walk in, we introduce ourselves, we're friendly, we might use some lighthearted humor if that's appropriate. We sit down at eye level, we make eye contact if that's appropriate in the culture of the family that we are with or the individual that we're with. We ask some questions, we give them time to answer, and we listen in an attuned, attentive way. And one of the main ways that we can tell families that we have heard them is to reflect back to them what we're hearing. I heard you say that you're really concerned about Johnny sleeping. Can you tell me more about that? This allies us with the family. We may not be able to build trust in the space of a short visit, but we have opened the door to trust building with that visit. And sometimes when families have had really negative experiences in the past with healthcare providers, it can take 3 or 4 visits before they feel that we're a little bit different, that they can trust us. But it is really being on that journey with the family that really makes all the difference. And that means turning away from our computers and having a conversation with people, even if it means we're going to have a little bit more charting to do outside the exam room when we're finished.
Well, thank you again to Dr. Szilagyi for all those thoughtful answers. I hope you all feel better informed on how to address ACEs and incorporate trauma-informed approaches to care in the pediatric setting. Thank you all for joining this evening. Please don't go anywhere. Stay on for some important reminders from the Landon Pediatric Foundation ACEs grant coordinators.
Thank you again for watching this lecture. Remember to complete the registration and evaluation. We will contact you soon if you are one of our raffle winners, so stay tuned.
Make sure to follow us on all our social media accounts and subscribe on our webpage for more information of our 12 lecture series, ACEs Aware Ventura County, and all things ACEs Aware.
Thank you for joining us on our mission to bring better help,
better health,
and better hope to Ventura County and beyond. Bye. See you at our next session. Thanks everyone for joining. Just as a few reminders, here are the QR codes if you still need them. And feel free to email us at acesaware@ventura.org if you have any questions. And we do have upcoming sessions coming up, so feel free to visit our website to register for those as well. Thanks.
Thank you.